Top Med Talk.
Welcome to Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Stand by for a healthy conversation. But first, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. It is organised by iPoets, the International Perioperative Testing and Training Society. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org. And remember, this is an International Perioperative Testing and Training Society accredited event. So when you attend, you can get your iPoets accreditation showing that you are a practitioner who has reached a high standardized level of competence in performing and interpreting cardiopulmonary exercise testing for patients preparing for major surgery. Check out ebpom.org now.
Hello and welcome to Top Med Talk. We're coming to you live from the World Congress of Anesthesiologists in Marrakesh in Morocco. And we're very privileged to be able to meet with some great leaders in anesthesia and to record part of our series, Periop Profiles. And it's my great honour and privilege, and I'm very excited, to welcome Bruce Biccard to the podcast. Welcome, Bruce.
Thanks, Kate. That's very kind of you. I'm excited to be here too.
Excellent. Bruce, can you tell us what your position is now before we go back in time to hear your whole story?
Yeah, thanks, Kate. So I'm now the Nuffield Professor of Anesthetic Science at the University of Oxford. It wasn't really planned. It sort of happened recently.
Excellent. Congratulations.
Thank
Do
you.
you have any other major roles?
My main role is Director of the African Perioperative Research Group. I'm also now on the board for IARS, and I'm also on the board for Safe Surgery South Africa, and they manage all the data and administration for APOC projects.
And you're pretty fit?
I'm quite fit, although I've been taken out by this cold.
But you ran across Africa or something, didn't you?
Yeah, and that's a ride. It's called the Race Across South Africa. Yes, I've done. Well, I've entered 3 times, finished once, and had a few mishaps.
Yes, I read an account and it sounded amazing. Maybe we'll get to that at the end of the podcast.
Lovely.
So I wonder if we could go right back in time and find out where you were born and where what your family was like, if you want to talk about that, and where and how you got to be a doctor.
I'm South African. I was born in Cape Town, 1969. Very sort of average middle-class South African family. My mom was a nurse. My dad was a salesman. It was in the height of apartheid. So it's got a lot of mixed emotions, which have been difficult to deal with. I think my education in the history of South Africa really started in earnest when I was at UCT, at the University of Cape Town. I think that for me was a very special time, being educated by my peers, people who I rode with, people who were in my medical class, our lecturers. And then during my time at university was when Nelson Mandela was released. And then his book was a very decisive moment, I think, in my understanding of South Africa. I suppose I've always been an African, and even though I'm in the UK now, I still consider myself African, and I'm only in the UK because I believe we can further the work we do in Africa.
And your parents were originally English? Is that or possibly French?
So, yes, very dodgy history. On my mother's side, they were French Huguenots. So arrived in South Africa in the sort of 1800s. My father's side is a bit more dodgy. I'm not quite sure of the whole family history. But I think mainly Scots-Irish.
And when did you decide that you wanted to go to medical school?
And unfortunately, I lived at a time where if you did well at school, you went and did medicine. And so it wasn't really something which I don't know, engaged with intellectually. And that's how I ended up in medicine. I think now I probably would have ended up in something with numbers, like actuary or something. I was much... Maybe I was much more that way inclined, and maybe that's how, over time, my research has moved towards epidemiology and quite a lot about numbers and understanding population health, that sort of thing.
Were you one of those kids who got enjoyment out of doing long division and all of that?
Probably, sadly.
So, what was it like going to high school and university in apartheid South Africa?
So, I suppose it's very distressing in that it was like living in a cocoon. You know, life just carried on as normal, pretty much unaffected with what was going on around one. And I think for me that's been the most distressing part of growing up and understanding South Africa, understanding apartheid, is how much one was sheltered from what was going on. I think through the way information was shared in the society one lived in. So I lived in what you would call a fairly liberal environment. But in reality, in retrospect, it was liberal in a white South African perspective, not in the reality of a democracy. And so, yes, I've battled a lot with that, and it's difficult to communicate. I tried to communicate it when I did my inaugural lecture at Oxford. I found that one of the most hardest talks I've ever had to do, but it was really important, I think, for people to understand where I come from or who I am.
Yeah. I don't think your experience of what sounds like, retrospective responsibility or guilt is your experience alone. I think that a lot of people wrestle with how to deal with the actions of their ancestors and their, the same thing happened in Australia about the responsibility for the colonisation and, the state of the Indigenous people. And, I think all credit to you for actually reflecting on that. And your career has made massive impact of redressing a lot of the wrongs that were done to the people of Africa in the colonial period, I would say.
Well, yeah, thank you. It is still very painful. I'm a very passionate South African.
Yeah.
Well, my intention was never to leave South Africa, and it was just through this work opportunity for our research that I have left. I intend to return.
Yeah.
I will always support the Springboks.
Yeah, they are. And what about the cricket team?
Well, I'll always support the Proteas as well. It's a bit more painful at times.
Yes, indeed. So it was an undergraduate degree in medicine that
That's
you did?
correct.
When did you get into anaesthesia?
The one thing I knew from med school was I would never be an anesthetist.
Right.
That was the only thing I knew, and then went to do my internship, and as soon as I had to do my anesthetics for registration, we had to do 40 or something like that. I really enjoyed it.
So what was it about it before you did it that you thought why it wasn't for you?
I think it was hard to understand its place in medicine. And the drugs just seem so foreign relative to the whole of the medical field. But I think once, you're in anesthetics and you understand it's like being an active physician and you do really cool practical things. But I really enjoyed it. And so I think we sell ourselves short as a profession, especially in the undergraduate space.
Yes.
We get too little time.
Yes.
People don't understand how we fit in the broader scope. And that as a profession, we're one of the most populous professions in medicine.
Yes.
And that's super important.
So back in the early 90s, I guess, when you were training as an anaesthetist, the volumes of practice that trainees in South Africa did was enormous. Not only the illnesses that the patients had, but the trauma, the violence, and then the HIV. That must have been great training, but possibly a bit stressful at times.
Yeah. I mean, the training was very hands-on. We did a lot. I think the hardest part really was that we didn't have the emotional maturity for what was expected of us.
Well, you were quite young, weren't you? Early 20s. Yeah.
Definitely. I think for me, one thing that really stands out was when I was doing pediatrics in my 5th year. I don't know, maybe I was 22 or 23. The ward, I think it was called A7. It was this pediatric emergency ward. Was just full of kids with basically dying from HIV/AIDS. And not really knowing how to deal with it. And the nurses who obviously had way more experience and way more emotional maturity and understood what was going on. It was how they managed to put things in context where we were all, I think, just trying to save a child, which was not possible. And I think for me, that was a super stressful time. In retrospect, I think in our training, we would have done much better if we had a lot more training and just understanding death. Yeah.
So when did you get into medical research?
2 things, really. I think the one is I've always been a nerd. So I've enjoyed...
This is Nerd Central here at Top Med Talk.
Oh,
so
good.
You've come to the right place.
I've enjoyed, seeing new things and what we would now call discovery science. That was the one aspect. But I think the second aspect is just as I was really getting into anesthetics, there was a whole beta blocker thing, which seemed just fantastic. We know now it's not quite what it looked like, but at the time you felt so empowered that there was something you could do that could change the trajectory of your patients. And I think from that perspective, it was really exciting. So I think it was a combination of those two.
Yeah.
And then I had the opportunity to spend a year with Pierre Foy and John Sear, and they were just incredible guys and mentors. So
did you spend time in Oxford?
Yeah.
Yeah.
So that was 2005, and I would say that was the start of my proper research, and I've got so much to thank them for because they were just great.
They're still just great,
I know.
aren't they? They're gentlemen of British anaesthesia. So did you do a higher degree?
I did a doctorate in KwaZulu-Natal, so after working with Pierre, I went back to Durban to carry on. I was a young consultant, and then I did a doctorate, and it was around cardiac protection with pharmacological, was really beta blockers and statins.
Yeah.
Not a fantastic piece of work, but it was more, I think it was an education.
Well, that's what a research doctorate is supposed to be, isn't it? Is learning research methods and learning about reflecting on what you've discovered and so forth. And it was such an exciting time. I mean, I'm very aware of your work because I was involved in the same area, in particular with the POISE study. You were a part of that too.
Well, yes, I was so fortunate because actually I was asked to come and do a talk in New Zealand. And while I was there, so this must have been 2005 or 2000, I can't remember, or just afterwards when POISE came out. The night before I was about to do my talk, John Sear emailed me and said, the POISE results have come out. And they had come out that night. And then I could talk about them and that. And then through that I met PJ. And then PJ was a really big part of my life and my education and my mentorship.
So that's PJ Devereaux from Astor University in Canada, and the POISE study compared metoprolol with a placebo and looked at a composite outcome of death and major cardiovascular complications. And famously, it showed that beta blockers prevent myocardial infarction, but they're associated with more hypotension and stroke.
Correct.
And boy, did that put the cat amongst the pigeons, didn't it?
It was the most amazing work. You know,
Yeah.
PJ comes from a hardcore evidence-based background with Slim Yusuf, and great work to show also how you need big clinical trials to answer important questions, because you miss the signals, like the stroke signal, if you don't have enough participants.
Yeah. So you got your anaesthesia training and you became a consultant in South Africa. Were you in the same hospital for the whole time you were working in South Africa?
So what happened was I did my undergraduate at Cape Town. Then I did my internship in Cape Town, went to the UK, travelled, locumed, and then I wanted to go back to do my anaesthetic training, and I ended up being offered a job in Durban, and so I went to Durban, which is in KwaZulu-Natal, did my training there, had a year with Pierre and John, and went back to Durban. Then I was in Durban for maybe 10 years, and then I moved to Cape Town.
And did you move to Cape Town to take up a leadership position?
In a way, they were very keen to grow perioperative medicine in Cape Town. And so I moved there, and then I was fortunate a couple of years after I moved, I was appointed to the second chair, which had been held by Rob Guy. He's a very well-known obstetric anesthetist, and he also was a very important mentor to me.
Yes. And was it that time that you started planning the ASOS study?
What happened was I actually went to EPOM meeting in London. So this is long ago now, maybe, I don't know, 2012 or something, and I heard Rupert talk about ASOS. And I thought, this is great methodology, and it's something we can do in Africa.
So ASOS was a prospective cohort study of outcomes in elective and emergency, or possibly...
Yes. Actually, the ASOS was just elective.
Yeah, elective surgery and 30-day outcomes, I think. And they all worked terribly hard for a week and collected loads of patients, and it was extremely interesting. And it's been published in the Lancet.
Yes.
Yeah.
So I heard Rupert present the results, and then that was how I met Rupert, and he shared the methodology. And then I wanted to organize the South African researchers because I felt we were too fragmented, and because of that we weren't doing anything impactful. So we set up a meeting, a few of us, to create the South African Perioperative Research Group, and we worked hard to get all the different role players into the same room. Built up a really strong case on why we should work together. And I was quite nervous, but we pulled it off. And so the first project we did was a South African surgical outcome study. And that actually set us up to do ASOS.
Yeah. So what were the challenges in setting up ASOS in... How long have you got, I guess?
No, you know what, I just think we were naive, and it's good to be naive in some ways. And so we just thought we could do it, and my surgical colleague, Tanankosi Madiba, and myself just basically cold called Africa.
How many countries did you get on board?
Embarrassing, I can't remember now. It was about 25, I think. So a good number. And it was built honestly on blind trust, because most of us didn't know each other. So I think that says a lot for the group and the individuals. Obviously, after ASOS and how well it was received, it's galvanized the group, and the groups just got stronger and stronger. So we were lucky. It was a lot of work, but...
And do you want to share the key results from ASOS with our listeners?
Yes, I can. So the results were quite distressing. The first was that the mortality was twice the global average, and this is not risk adjusted. And when you look at what the patients looked like in Africa, they were pretty much fit and healthy. And so risk adjusted will be much higher than that. And failure to rescue was twice the global average. So very strong signal, but also a very good signal in where we could put our efforts to improve outcomes. So distressing, but super useful. And then we basically pivoted to do a big cluster randomized trial across Africa. Again, totally naive. We thought, if we can point the clinicians or the health workers in the right direction of the patients at risk, you should be able to make a positive impact on outcome.
So you randomized people to a failure to a rescue strategy. Is that correct?
Yeah. Well, it was a very simple thing. It was really flagging high-risk patients and then advocating for increased surveillance. And we had about 5 interventions, and that's what we suggested. And we thought, well, with that sort of environment, we'll definitely be able to save some patients. The reality was that we recruited nearly 30,000 patients and we made absolutely no difference. So that was super distressing, but wow, was it educational?
Yeah. What was the intervention?
So the intervention was we would risk stratify with a surgical risk calculator we had made from ASOS, which actually works quite well and it's continued to work well. So that part was fine. And then the high-risk patients would either get increased observations, be put in beds closer to the nurse's station. They could have their family with them if needed to alert the staff. They had a sign above the bed saying they're high risk and some ideas on what to do if they're deteriorating before the team arrives. So that pretty much was the package. But the reality is, I think, between the theory and the action or intervention, there are all those processes, and the fidelity in the processes is what we learned about. So I learned a lot about implementation through that. We've been working now for a few years on a package to do this with IHI and through a grant with the NIHR. Really quite difficult. But I think we're getting to a point where we might have a implementable package. And so if it's looking good, and if we can take it to the next step, then we'll try and scale it for Africa.
Wow. So, Nobel Prize, here we come. Bruce is so modest, he's sort of going, oh, shucks here, mate. But, the die is cast for many of these patients before they even get their surgical issue diagnosed.
Correct. So I think that's a very important point, and people need to understand that, realistically, if we do really well, we hope for a relative risk reduction of maybe 20 or 25%. If we got that, it would be phenomenal, which means for every 4 patients, only 1 is going to get the benefit.
Yeah.
So, I think for the listeners, when you're looking at reading papers and that, first thing you must go do is look at the sample size and the expected relative risk reduction, because it'll tell you if they are really locked in or pie in the sky stuff.
Yeah, exactly.
And that's why you need big numbers.
So what inspired you to go to Oxford? What are your hopes and dreams for that role?
There are 2 hopes and dreams.
Yeah.
Or 3. So the first is obviously global health. So for me, global health's front and center, especially because about 80% of the population is going to be living in low-resource environments or from low-resource environments by the end of the century. So this is not a problem which is going away. Even though the world on the whole is getting better, the reality is this is still a big problem that needs to be addressed. I believe that in Oxford there's a lot of human resource skills which can add to the work we do in Africa. So I think we can do good practical clinical research but I think we're limited by our human skill set. And if we can bring some of that expertise into our network, I think it'll make our work more impactful. So that's a hope for that. Then the second part is obviously about Oxford. So the anaesthetic department or division sits within the Department of Clinical Neurosciences. It's a very strong department with a lot of skills across a range of things, and I do believe perioperative cognitive dysfunction is a massive challenge for us, particularly in high-income countries where the population is getting really old and the ambition for surgery is getting very ambitious. It's a tricky balance. When do you deny patients surgery because you worried about their cognitive dysfunction or the impact on their cognitive dysfunction? I think I would like to see Oxford contributing more to that. And then finally, I think for me, the integration of the clinical service and the university service is very important.
Sounds like a great plan, and if anyone can make that happen, it's you, I think.
Well, it's kind of you. We'll see. I hope people believe in that.
And what do you and your wife think about living in sort of semi-rural England and the weather?
It is very tough. Tough in winter. I mean, now that's starting to turn quite quickly. The summers are beautiful. Suddenly now I'm on my bike into the evening, which is very nice. But yeah, the darkness and the cold, it was quite brutal in January and early February.
But to live close to a major hub like London and with immediate access to the rest of the world must be a pleasant change from trying to get anywhere from Cape Town.
Absolutely. I mean, there are so many fantastic things about where we're living now, and we need to embrace those and enjoy them. So my wife and I go to a lot of the open lectures in Oxford. I mean, there's incredible stuff which is going on all the time, so that's fantastic. And yes, getting onto the continent and spending time in London, it's exciting. It's just different to what I would have been doing if I was in Cape Town.
Yeah, well, you need to stay on your bike.
Yes, I should try that.
Yeah. Well, Bruce, it's been marvellous talking to you. You're such an inspiring person. You come up in everyone else's periop profile as someone that they admire, so it's great to finally have had you on and chat about your life.
That's very kind of you, Kate. And thank you. Thanks for promoting our work.
Anytime we can help, please tell us, because it's so fascinating and so beautifully done. I mean, when I was talking to Rupert Pearce, in his periop profile, we discussed your work, and we both remember the time in Italy when we first heard the results, and what an emotional experience it was to see you with those mortality figures, particularly in young women having caesarean section. And I remember afterwards about 25 major journal editors came rushing up to you, which is something that all researchers wish would happen a bit more often.
But I think, just in closing, one's got to acknowledge how fortunate we are and in how people help promote what we do. So, I mean, what you talk about, Paul Miles, and creating that meeting and giving me a platform to be there. I've been very fortunate. I've had a lot of people who've supported me and our group and the work we're trying to do. And I think, a lot of this is other people really creating a path and an opportunity for you. And to those people, I'm most thankful, and there's lots of them.
Yeah, well, gratitude is a great quality to have, and it's appreciated by everybody. So thanks very much, Bruce.
Thank you.
You've been listening to Top Med Talk. You can find this podcast on our website. You can download it via your podcatcher. And please do follow us on social media. We're on LinkedIn, we're on Instagram, Twitter and Blue Sky. And if you like what you hear, give us a big thumbs up and share it with your friends. We'd like to thank our sponsors, who are GE and BD Advanced Patient Monitoring. And we'd like to thank the WFSA for their hospitality at the World Congress of Anesthesiologists in Marrakesh. Cheers.
Top Med Talk.
And remember, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org.